Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for tonight's program on skin problems. We'd be glad to take your calls on skin cancer, eczema, psoriasis, and any other skin problems that you may want to call about. The success of this program is very dependent on you, the viewer, so please call in your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Susan Ash, a dermatologist with Essentia Health, Dr. Heather Buchholz, a dermatologist with St. Luke's Dermatology Associates, and Dr. John Wood, a family physician working in the emergency room at the Grand Itasca Clinic and Hospital in Grand Rapids. Our medical students answering the phones tonight are Sarah Burke from Morris, Minnesota, Megan Hall of Madison Lake, Minnesota, and Ryan Wilson of all the way from Alaska. And now on to tonight's program on skin problems. So we'll start with some common issues before we get the call-in questions from the people calling in. So Dr. Ash, let's talk about dry skin in the winter.
Oh, that seems to be a pretty common complaint these days. I have a lot of people asking me, what do I do about my skin? It's so itchy, it's so dry. And one of the first things I say are you using a lot of, do you use soap? And they're like, well, of course I use soap. But I tell them that soap can actually be really harmful, really drying to a lot of people's skin. Not everybody can handle soap. And I tell them to be careful where you use it. Maybe use it in the areas that you need to, like face, underarms, the private areas. So avoid it on your arms and legs. And that's really going to make a big difference. The second thing you can do is to really moisturize after the shower, after the bath. You want to lock in that nice moisture that you got in the bath. And so within 3 minutes, you want to put on a nice moisturizer. And in the summertime, I think lotions are okay, but in the wintertime when it's drier, I prefer a cream, or even better would be an ointment. And ointments can be kind of greasy, but there's some that rub in nicely. I like Aquaphor. Vaseline works good, but if you can get a moisturizing cream would be even better. So you want to do that right after the shower, and if you could do it another time of the day, that would be good. So I tell people, be careful of soap. Don't use it if you don't need it. It includes body washes. You're probably not getting that dirty. And then really moisturize. And also it goes with hand washing. You want to be careful how much you wash your hands on the back of the hands. Try not to use too harsh of soaps, and really moisturize well afterwards. So
what about the little cracks that you get in your along your fingernails? And
well, I ask people, like, do you wash dishes by hand? And they're like, oh, yeah, I wash dishes. So I like to have people, you know, if you can, put your hands in those kind of big Playtex kind of rubber gloves when you're washing dishes, because that soap, that detergent is really going to chew up your hands a lot. So if you can wash your hands, or keep them out of the soap as much as possible when you're doing dishes, and then when you're washing hands, I like a gentle skin cleanser called Cetaphil is one of my favorites. So it's not as drying as the regular detergents. You wash with this gentle skin cleanser, and it doesn't dry out as much. And then when you're done, again, you wash, after washing your hands, you put on a nice ointment if you can, or a cream, and soften up. And do that several times a day. And that really seems to help with those cracks. It'll take some time to get them to go away, but if you really follow that kind of regimen, it should clear up.
Excellent. So another question Dr. Buchholz will ask you is that people are probably taking winter vacations. And so there's always the question about whether they should get a pre-tan before they go on a southern vacation.
Yeah, I'm hearing that question almost every day in my clinic. People are going on vacation, and can I use a tanning bed just a few times to avoid that sunburn? And it's, I think they know the answer when they're asking me the question. Of course I'm not going to recommend you use a tanning bed. And I'd rather just have them be really intensive about their sunscreen use while they're on the vacation, because if you are getting a tan, you're already causing some DNA damage that's inducing that tan. So I guess I do give them this analogy that, you know, it's like getting a tan before you go on vacation is kind of similar to smoking a few cigarettes before you get ready to smoke a full pack. Of course, you know, little's not good. So, yeah, I think just trying to remember when they're on vacation to use sunscreen, an SPF of at least 30 with UVA and UVB protection, and reapplying it every about 2 hours if they're outside all day.
Excellent. Well, Dr. Wood, we'll talk a little bit about the ER to start with. And what kind of common rashes are you seeing right now in the wintertime?
Well, yes, most of the time the common scenario would be a parent that comes in with their child because their child's sick, and often their child will have a viral infection. And in the winter, viruses are probably more common because we're in enclosed spaces. We cough and whatnot on each other. And so kids will get viruses very commonly. A lot of those viruses can be basically categorized in just 3 or 4 groups. And a really common one might be erythema infectiosum, or the slap cheek. Some kids will get a slap cheek kind of look. Or another one might be roseola, which is a kind of a truncal rash with a fever, also caused by a herpes virus. Another one might be the hand, foot, and mouth disease, or Coxsackie virus. I've seen all those in the past few weeks. Less seasonal, but very common, and we don't see it as much now because of immunizations, would be chickenpox, which is a standard 10 to 14 days of a rash that comes in waves all over the body. You can have probably 250 or 300 papules or pimples with, classically it's described as a dewdrop on a rose, meaning a nice rose petal with a little clear vesicle on it or a little pimple. But we don't see that as often. But I'd say most commonly in the winter it's those 3 first viruses, or your common cold with a lacy kind of a reddish rash that's on the trunk that's associated with a fever. Most of these are very concerning for the parents, but as practitioners or physicians, it's usually not something we're too worried about. The common treatment might be Benadryl, Tylenol, Motrin, and thyme. Thyme's usually the best ally, I think, for most skin diseases. My colleagues would agree, I hope.
Yeah,
but
absolutely. Yeah.
Especially viral.
Viral
infections.
things usually go away. Yeah.
2 weeks,
Yeah. You'll be.
14 days. Oh, Dr. Buchholz, ichthyosis. They're asking a caller from Superior if you could just describe what that is.
Ichthyosis is just describing really dry skin, and it's kind of derived from the word for fish, like ichthyology. So it's just severe dry skin, and at this time of year we definitely see a lot of it, like at the shins. And there's actually quite a few different genetic diseases that fall into that category. And the most common one would be ichthyosis vulgaris, but it's just a condition that predisposes you to really dry skin.
It's a great question, but it's probably complicated as far as psoriasis. If we have anything for 100% cure for psoriasis, Dr. Ash.
I wish we did. We don't have a cure for psoriasis. There's many different ways we can try to work at it a little bit, but we don't have a cure. We try to, we still use topical steroids a lot. We still try to manage it topically if we can. If it's extensive, we'll maybe add some phototherapy, and that's one of the few cases I would add, advocate for someone going in one of our special light booths, and that can help psoriasis. That's working on the immune system also topically. With the light, it can suppress the immune system in the skin. It seems to be immune mediated in some way. A lot of genetics play a role. So it's hard when they say it's multifactorial, the things that cause it. So if there's not one thing that causes it, it's hard to find a cure. There's also some oral medications, some systemic medications that we can use if you have really significant psoriasis. There's some medicines that can be very helpful, but of course they could have some side effects too, and so they are monitored very frequently. So I wish we had a cure, but we do have some things we can use to help people, especially if it's severe.
And does it get better in the winter or summer? Is there any correlation with that
A lot
at
of
all?
times it gets worse in the wintertime, and again, it's related to the sun. Sun seems to help psoriasis. It's probably suppressing the immune system in the skin. And then the wintertime, when your skin is really dry, psoriasis gets worse too. So that's where the dry skin care really does seem to help a lot too, moisturizing. But maybe someday we'll have a cure, but not yet.
Not quite yet,
Not
yeah.
yet, fortunately.
Well, a caller from Two Harbors, Dr. Wood, asking about shingles or herpes zoster. You could talk about that just a little bit.
Well, herpes zoster is the same virus that also causes chickenpox. So what happens after a case of chickenpox is that the virus is still present. It's been cleared from the body, at least. It looks like it's been cleared from the body, but what happens is that the virus essentially goes to a dermatome or a head of a nerve fiber, usually commonly in the back or anywhere in the body. And what will happen is that virus is still present but will lay dormant. And then if you have an incident where, say, your immune system becomes suppressed, let's say under stress, perhaps an illness, perhaps a chronic disease, that might flare up. It can happen in children, it can happen in adults. And typically what will happen is the patient, when you think about it, I've seen this happen. You come to the doctor's office and something just doesn't feel right on the skin, but you can't see anything. Commonly what will happen a couple days later, they'll start to develop a rash. And the rash is typically on one side of the body, and it's typically in a dermatome or a skin or a nerve distribution, either in the face. And the face would be the most concerning because sometimes that can affect your eye, or on the skin, more commonly on the skin, but certainly in the eye itself. The treatment, it's a difficult disease to treat because there's a complication called post-herpetic neuralgia, where you can get chronic pain because of the nerve damage from the initial infection. Typically what will happen is if a patient comes in within 3 days, you can treat them with something called acyclovir or a similar antiviral medication. Sometimes steroids are used, sometimes not, sort of depends on the case. There is a vaccine, which is maybe the caller's heard about that, which is also used, and that can be used for people that have had shingles or have just had chicken pox, and I would recommend that. I think it's believed over 50, and it can help prevent that disease because it's a pretty debilitating. If you get that post-herpetic neuralgia, it could be a chronic problem and very difficult to manage once you do have that.
More chronic pain medication.
More chronic pain at that point, and a sense that this is something that's chronic and painful that could potentially be prevented. You'd probably want to do that if you could, so I'd recommend that.
Dr. Buchholz, several callers asking about rosacea. So maybe you could talk just a little bit about rosacea.
Right, so rosacea is a very common problem, especially in our population up here, and it's usually characterized by either kind of dilated blood vessels of the cheeks causing rosy cheeks, or else sometimes a pimply type presentation, and it sometimes can involve the eyes, causing a gritty sensation or redness in the eye too, so it's a very common problem. Sometimes it's more of a cosmetic concern, and sometimes it's really the symptoms of the eye irritation. And there's several different treatments you can use. Topical antibiotics in the form of like a gel or a lotion can be helpful. There's also antibiotic pills, especially if you have eye involvement. And some other precautions I usually recommend taking with rosacea is just to be very careful with exposure to sun. There are different triggers for rosacea, things that can seem to aggravate it, like alcohol or hot beverages or exercise and kind of all the pleasures in life, chocolate, coffee, wine, will make rosacea flare. So just trying to keep those in moderation is another idea.
Thank you. Very helpful. So a caller from Cloquet, Dr. Ash, asking about microdermabrasion. Can you talk about that just a little bit?
It's a cosmetic procedure that you can have done, and some people will use it for acne or just to kind of smooth out some fine lines or make your skin feel a little bit smoother, softer, maybe a little tighter. It's basically a procedure when they kind of, I think of it kind of sanding very superficial the top layer of the skin, almost like little beads of silica. They'll kind of blast against your skin, and it just kind of buffs it. It's nothing permanent, so there's really not a big downside of it. It can maybe irritate rosacea. But it's kind of like a facial almost, but nothing long term, but it feels nice afterwards, and your skin is smoother, and you look a little bit brighter for a while.
Yeah. Little glow.
Little glow.
So Dr. Wood, a caller from Duluth asking about contact dermatitis.
Oh.
Probably see that in the ER.
See that in the ER fairly, I wouldn't say fairly commonly. I'd say it's essentially an allergic reaction to something. It could be poison ivy, poison oak, certain cream you'd put on, perhaps an article of clothing. Nickels are a very common allergen. These are unpredictable in the sense that people usually, once they've been exposed to something, they realize they're allergic to it. They'll try to avoid that in the future. But often it'll present with, the skin will be red, irritated, weepy. You might have some blisters on the skin, sense of irritation and itchiness. It can be very distracting to the patient, and potentially very, cosmetically an issue if it's on their face, perhaps. If they've, and that would be this is something we'd see in the ER pretty commonly. The treatment would be steroids, usually, because that can suppress the immune response, help calm it down. There are creams you could use. Often the issue is, though, that you're a little nervous about applying a cream in the emergent situation because you don't know if it's going to cause more irritation, but commonly you probably use a steroid cream for that. But typically I'd say it's some type of irritant that you weren't aware of that has irritated your skin, and your body's just responding to that.
And you definitely have to remove the allergen.
Definitely have to remove the allergen. Thank you. Clothing, whatever it is, metal. Obviously, if it's poison ivy, you have to try to avoid that, meaning recognize what it is, or poison oak.
Just go in the woods if you can avoid it.
Yeah. I'm all for going in the woods, but maybe just watching those leaves of three, that kind of thing.
Dr. Ash, just a caller follow-up on psoriasis, about psoriatic arthritis. Perhaps you could explain the definition.
When you have psoriasis, you can also have involvement of your joints called psoriatic arthritis, and that can be sometimes rather significant, and I'll send people to the rheumatologist if I feel that they have a major arthritis component to their psoriasis. So I always try to ask them about, arthritis. And some of the medicines that we use for psoriasis will be helpful for their arthritis as well. They can have a lot of stiffness of several of their fingers. They can be swollen, red, tender. It can happen several different joints. But that is something that some people might have just a little bit of psoriasis and a lot of the arthritis component of it, but it can run together definitely.
And a skin cap for psoriasis? I'm not familiar with that. A skin cap?
There used to be a medication on the market called Skin Cap, and it worked beautifully for psoriasis. And people were like, wow, this is the best medicine ever. But then they found out that it actually contains a very powerful topical steroid. And so it was taken off the market. So I don't know if that still exists without the steroid, but I know that the steroid they had to take out of it. But it was nice for a while before we realized what was going on.
Oh, Dr. Buck, let's talk about, there's a caller asking about MRSA. Maybe we explain MRSA a little bit.
MRSA is methicillin-resistant Staph aureus, and so it's a bacteria that's really, the staph bacteria is really common on people's skin, and when it acquires a resistance to some of our more commonly used antibiotics, it can be a real problem. And the first infections were seen mostly in hospital or nursing home settings, and now it's actually really quite prevalent in everyday life in the community, in schools, and so it can cause painful skin infections like boils, or even more serious infections and skin infections too. So that's kind of a growing problem. So I think we just need to be real cognizant of that and find ways to kind of sparingly use our antibiotics to preserve their effectiveness with treating other diseases. So.
And I think this is just one other point. Often in the ER, you'll see people that have an abscess or a boil, and they often don't all need to be treated with antibiotics if the abscess is lanced and drained. And the reason I mention that is because it's important to try to minimize antibiotics. And sometimes you need, like to treat MRSA, you'd use Bactrim or vancomycin, which are more powerful. At least the vancomycin is. Bactrim's been around a long time, or sulfa. But sometimes people are allergic to antibiotics, and that's an issue. But I guess the point I'd make is that sometimes you can treat these MRSA things, but at least an abscess or a boil. If you drain it, sometimes you don't even need antibiotics.
Which leads to the next question for you, Dr. Wood, as well, because they're asking about sebaceous cysts.
Okay.
And difference between a sebaceous cyst and a boil.
Well, a sebaceous cyst, hopefully I'm looking at my dermatology colleagues, but I'll try my best. We have oil secreting glands on our skin, often at the base of a hair follicle and in other places, but these are sebaceous cysts, or sebum is the oil that's produced. And sometimes what you can get is a cyst or collection of fluid under the skin. Sometimes those can get infected. If they get infected, sometimes they can lead to boils, but I wouldn't necessarily say they are boils. Sebaceous cysts, sometimes cosmetically they can be an issue. You can get something called a WEN, or W-E-N, which is seen on the scalp, which is kind of a lump. You'll see people sometimes with something like that. Those can be excised without too much difficulty in the office, and they aren't infected. But a sebaceous cyst by in itself is a natural phenomenon. The issue is whether it becomes a cosmetic issue, I think. Or they can often get infected. If they get infected, they need to be treated, and sometimes they need to be surgically removed, which again is an outpatient procedure. It can be done in the office.
You kind of have to make sure you get the
cyst, the wall of the cyst. You sort of have to shell the cyst out, and easily the practitioner, the physician can. Sometimes you miss some and it comes back. You know, it can be kind of frustrating for people.
Yeah, it seems like some people have a real predisposition to form these cysts or epidermal inclusion cysts, and so you might remove one cyst on their upper back, and then 5 years later they've got a new one on their lower back. So it can be really problematic for patients.
So Dr. Asha caller asking about skin tags. Sometimes we see lots of people that have them on their neck, under their arms. Very common.
Yeah, I see. They're harmless. I mean, sometimes they get pulled and become very tender and sore, and then they're painful, and you want to get rid of them. But they're basically a harmless skin condition, and some people just seem to be more predisposed than other people. They seem to occur along areas of friction, like the neck or the underarms or even the groin. And the skin, I think, just gets kind of pulled to the point where it just kind of forms this little tag, this little floppy piece of skin. And if someone comes in and they don't like them, oftentimes I'll just freeze them with liquid nitrogen if they're small, or I'll inject them with some lidocaine and then simply do a little small scissor. They don't feel it, and I just remove them. So, and I just tell people, they're harmless. If they bother, they can be removed, but you don't have to.
They don't change to cancer at
all.
all.
They don't change to cancer. You can just kind of ignore them if they're not bothering you.
I think that for a lot of people, they catch on necklaces
I think
and
necklaces
jewelry.
kind of promote it, the friction of the necklaces. It seems like those people tend to get more of those skin tags.
Yeah. Well, Dr. Buchholz, big topic, treatments for eczema.
Oh, great. So we talked a little bit about atopic or contact dermatitis. So another form is atopic dermatitis or eczema, which somebody has kind of a predisposition towards sensitive skin or dry or itchy skin. So the first thing to remember is just what Dr. Ash went over with gentle skin care and just making sure you're doing your best job to hydrate the skin. And then for treatments also, we can do topical steroid creams or ointments. Sometimes we'll use the light therapy or phototherapy just as we do with the psoriasis patients for more severe eczema, and also that you can use antihistamines to help prevent itching in patients with eczema. And there's also some stronger medications to try to suppress the immune system to treat eczema. But the foundation of it is gentle skin care and regular moisturization.
All right, how about some ABCs of skin cancers? I have some callers asking about how do they differentiate and know when they should go to the doctor or not.
Well, we were talking about this earlier. I won't talk about, there's something we discussed, but we won't mention that on the air, but we'll go into something else. There's basically A, B, C, D, E. We'll make it simple. All of us have moles, okay? And then the issue is some people can have hundreds of moles, and other people not so many. But asymmetry would be the first, is the mole, when you look at it and divide it in half, it should be the same on both sides. Another thing is the border. The border should be smooth, kind of pretty regular, not all notched and everything. The other is the color. Colors like black or red going to black, very deep violets, those are concerning colors. The diameter, it should be less than the size of a pencil eraser. E would be evolution. Is it changing over time? Often the spouse will notice something that the patient can't see because it's on your back or wherever. And so that would be the other thing. I think when in doubt, and maybe you'd agree, that the idea is to come in and get it checked out by some trained eyes, as opposed to thinking it's probably okay or looking it up on the internet, or there's mobile apps on your phone you can buy. I guess I'd discourage people from doing that and recommend that they get a trained person to look at it, dermatologist or your primary care physician at least.
Yeah. And we would, if a patient was referred, like punch biopsy, Dr. Ash, when you talk about punch biopsies.
If it looked worrisome, yeah, I would do a punch biopsy and send it to pathologist, and they would make the determination if the rest of it or more need to be taken off, or if it's just fine. Yeah. I usually add to that when I'm seeing someone have lots of moles, I always tell them to look for the ugly duckling. Look for the mole that doesn't look like the rest, especially a new mole. It's something that seems to be changing, but something that doesn't seem to be fitting with the others. The little ugly duckling sign can be very helpful.
It's definitely important to kind of take it in the context, and you want their moles to kind of look very similar one to the next. And people with different complexions tend to make different appearing moles, so it's really helpful to have some other moles to compare it to. And then the one other thing I add to that is new symptoms. If you had a mole that you've had for a long time, but suddenly it's always tender or itchy, that would also be a little bit concerning.
It's hard. It's hard for people. They can't see their backs, and they can't.
Right.
They need to have somebody else check them, and it's a big question for a lot of people.
So if someone says the mole looks like it's different, take their word for it and get it checked out. Don't wait. There's lots of stories about people that have waited, and then if you wait too long for a certain kind of mole, it's really too late, a melanoma that might have metastasized. So I would encourage.
And on treatment for skin cancer, what's the most common treatment? I mean, do we take them off, or do we, besides biopsying, are we just removing them?
There's different kinds of skin cancer. It kind of depends on which one it is. Certain kinds, like the basal cell carcinoma, sometimes you can get by with. There's actually prescription cream that you can use for a superficial one, or we can scrape those off sometimes. A squamous cell carcinoma we usually cut out, as well as the melanomas. The melanomas would have a much wider excision, and sometimes the lymph nodes are evaluated too if it's a certain depth of a melanoma, depending how deep it went into the skin. So it kind of varies on what kind of skin cancer, then on how deep or aggressive it looked on the microscope.
So we only have a minute left or so. Dr. Buchholz, go back to the tanning beds and that topic. So lots of callers are asking what strength of sunscreen should they utilize?
That's a great question, and I try to encourage all my patients to wear sunscreen every day, even in the winter, on their faces, and I'd say SPF of 30 at least, with UVA and UVB protection, and reapplying it if they're going to be outside for more than 2 hours. And then the other key thing is you have to apply enough sunscreen to get the SPF advertised. It's true that the really high numbers aren't needed if you put on enough, but if you were using, like if you look at a typical Neutrogena bottle of sunscreen that you paid $8 for, if you were using as much as they do to test it and generate those numbers, you'd probably be buying a new bottle of sunscreen twice a week in the summer if you're wearing shorts and a t-shirt. So it's just a matter of, I do go high with the SPF just because I don't think people really apply enough to get what's advertised.
Well, thank you. Our time is up. So I want to thank our panelists, Dr. Susan Ash, Dr. Heather Buchholz, and Dr. John Wood, and our medical students, Sarah Burke, Megan Hall, and Ryan Wilson. Please join Dr. Alan Johns for a program next week on ENT problems, when his panelists will be Dr. Todd Freeman, Dr. Jonathan Glickstein, and Dr. Susan Nordine. Thank you for watching. Good night.